name's Jacob. I'm a final year medical student at Lancaster Medical School. Welcome to part 3 of this gastroenterology series, where we're going to be talking about spontaneous bacterial peritonitis. I'm going to be referring to this as SBP throughout the video, since spontaneous bacterial peritonitis is a bit of a mouthful to say every time. Okay, so first of all, let's talk about Ascites complications and the mechanism which leads to the development of SBP. Okay, so we know that in patients with liver cirrhosis, they have reduced liver function and also portal hypertension. So let's talk about the reduced liver function first. So because of the reduced liver function, there's going to be decreased bile salt formation, therefore reduced bile salt antibacterial activity. We're also going to have less factors of the complement system being synthesized. Therefore, there's going to be reduced membrane attack complex formation. So we've got this innate immune system dysfunction occurring too. And we also have portal hypertension, so therefore there's going to be a backup of less oxygenated blood into the splanchnic, otherwise known as the gut circulation. Therefore, there's going to be reduced oxygen to the intestines, reduced peristalsis, and then an increased intestinal transit time. So we're going to have lots of stagnant contents within the intestinal lumen. And all three of these factors all contribute to bacterial overgrowth within the intestinal lumen. And these bacteria can translocate, they can move into the ascitic fluid. And they can do this via one of two mechanisms. Okay, so first of all, we have transmural migration, so where the bacteria migrate directly across the intestinal walls to seek out the nutrient-rich ascitic fluid. Or we have hematogenous spread, so the bacteria move from the gut into the systemic circulation. The liver's reticuloendothelial system, so part of the immune system, can't clear them, so it can't clear the bacteria, allowing them to migrate into the ascitic fluid. And this leads to spontaneous bacterial peritonitis, SBP, where we have an ascitic fluid neutrophil count of greater than 250 cells per millimeter cubed or per microliter. Okay. And neutrophils are a type of white blood cell. They're a granulocyte because the cytoplasm's granular. Other granulocytes are basophils and eosinophils, and neutrophils are involved in the acute inflammatory response. So let's talk about some of the clinical features and symptoms what patients might experience when they have SBP. It's important to remember that patients can also be asymptomatic. So patients can have a fever, and the absence of a fever doesn't rule out SBP. Patients who have liver cirrhosis have at a baseline are typically hypothermic. So if they develop a fever, you want to be thinking, right, there could be something which isn't quite right, which needs further investigating. Patients might also have chills, abdominal pain. Remember in your physical examination, you might be able to elicit some guarding or rebound tenderness, indicating that parietal peritoneal involvement. Patients might have diarrhea, paralytic ileus. Do you remember that was related to the backup of blood due to the portal hypertension? So we're going to have less gut peristalsis occurring, and then they might have new onset or worsening mental status. That could be related to, if they have cirrhosis, related to worsening hepatic encephalopathy. Or they could have new onset or worsening renal function. All right, and renal failure is probably the main complication of SBP. We're going to talk about that later in the video. So let's talk about the diagnosis of SBP. So I've used this term before, paracentesis. So that's where we use a needle to sample some of the ascitic fluid within the peritoneal cavity. And also previously mentioned, it's diagnostic of SBP when the neutrophil count is greater than 250 cells per microliter. Some of the organisms what might be isolated include E. coli, Klebsiella and Klebsiella pneumonia, and these are gram-negative enteric, so within the intestine organisms, and this supports the transmural migration theory over the hematogenous spread theory. Okay, and then If a patient's also having peritoneal dialysis, you can sample the ascitic fluid using that method as well. So that's worth mentioning. 2, additional investigations, blood and urine cultures. So that helps to guide the empirical antibiotics and locate the source of infection. But remember, the most important diagnostic method is the diagnostic paracentesis. And you might remember this diagram from the previous video. This just essentially illustrates the points at which the needle is inserted when performing diagnostic paracentesis. So let's talk about the management of SBP. So the first thing we want to think about is empirical antibiotic therapy, and this is going to be based on individual trust guidelines. So we typically use a 3rd generation cephalosporin. Okay, and then after we've given the antibiotics, we want to do a follow-up ascitic fluid analysis, and the neutrophil count should have decreased by roughly 25% in 48 hours. If not, this could suggest that there's an abscess formation or viscous perforation, and we could have secondary peritonitis rather than spontaneous bacterial peritonitis. That's an important. It's important to basically distinguish between them two complications, because SBP we know is related to liver cirrhosis. Secondary peritonitis can be related to a number of things, and that's where we have irritation of the parietal peritoneum. That could be through complicated cholecystitis, appendicitis, mesenteric ischemia, or even hollow viscous or organ perforation. Okay, so for example, if you had perforation of the small bowel, the contents can irritate the peritoneum, etc. We also might want to consider some intravenous albumin for SBP, because albumin helps to maintain that oncotic pressure, improving the renal perfusion, preventing renal failure from happening. Because like I mentioned, renal failure is the major cause of death in patients with SBP. And if you did actually in fact determine that the patient had secondary bacterial peritonitis, they are most likely to require surgery. Okay. Some patients might be eligible for outpatient antibiotics, such as quinolones like norfloxacin, ciprofloxacin. If they've had previous SBP and associated GI bleed, or if the ascitic protein count within that ascitic fluid is low. And then you also might consider using ceftoxamine if the concerns of fluoroquinolone resistance. Complications of SBP include renal failure, liver failure, sepsis. And alcoholic liver disease is a very poor prognostic factor in SBP. Okay. So that's it. Only a short video today. I hope that was a good summary. Thank you for watching, and I look forward to seeing you next time, where we're going to be discussing hepatic encephalopathy in more detail. All right, so take care, and I'll see you in the next video.